protozoas, when we talk about our different parasites, just understand that they're going to hijack that host, right? They need somebody to help them survive. So when we're looking at our protozoa, we can sometimes say we have intestinal ones and we have our extraintestinal parasites. And so when I give you your exam, it will have what their disease state is. Again, you are not diagnosing. So a lot of this stuff where you see like the symptoms and all that, that's just for a complete picture. And it helps some people because I may write a stem that has the symptoms in there, even though I'm going to tell you, but people are like, oh, they have a lot of diarrhea. I remember that one. So I try to give you more than one way to kind of associate some of this stuff. So I will tell you what their issue is, and you're going to say, hey, here's this drug, or here's how I'm using this drug. So in this one, in this lecture, a big thing is knowing what disease state you're going to treat, know which drug you're going to use, and if we're talking about prophylaxis, cool, when can I start it, or when can I not start it? Like, when am I ending upon return? Because some of these meds will, and I don't even like test you on that. We're going to focus more on like, when do I start? So let's say I was going out of town really soon, you're probably going to need to know which drug you can start me on because I came to you a week before I left instead of a month before I left. So you'll see this as we go through where that's the kind of thing I want you to focus on. The ages at which you can start some of these medications, we'll talk about those. I want you to focus on those ages because that's a big deal. A lot of these meds you are going to prescribe, and that age cutoff will matter. And those are like your big focuses whenever I'm talking about like exam-wise, okay? So how they get it, this is all just background up for us. So we're gonna focus on malaria, trichomonas, and then your toxoplasmosis. All of these, we're gonna talk about some of them, and then we have some additional ones that we're gonna look at as well. Looking at malaria, all you need to know, a mosquito bit somebody, laid some eggs, and then we have a problem. We have malaria, okay? So when I'm looking at this, I don't need you to remember this whole cycle or any of that. What I want you to look at is how you have a liver stage and you have a blood stage, okay? When you look at your liver stage, here are your different medications that you can use in the liver stage, and these are the different medications that we have available for us to treat that patient in the blood stage. We have some medications that will be in both the liver and the blood stage, okay? We have some medications that we're going to talk about for resistance. So if somebody continues to have that relapse of malaria, we have other medications that we're going to say, hey, I'm going to put you on these, we reserve those, okay? So anytime you hear resistance, and while we're talking about like this block, anytime you hear resistance, most of the time that is going to be like our big gun for whatever that disease state is that they're resistant to, okay? Group 1, where are you? I'll bring it to you. You don't have to stand, y'all can sit. If you want to walk around, you can do that too. It's up to you. And y'all can pass and you can tell me next and I'll go to the next slide.
Can everyone hear me? Alright, so for antimalarial medications, like Nim said, you have the liver and the blood stage. So for mechanism of action, you really need to know the differences between the hepatic stage schizontocide, the hypnoticide, and the blood stage schizontocide. So for the liver stage, if you remember, the sporozoites enter the liver and they do asexual reproduction into the schizonts. So that is what your hepatic stage schizontocide is targeting. So the schizonts in the liver stage. And then you also have the hepatic stage hypnocytes. So remember, some malarials reside like dormant in the liver as hypnocytes. So this middle, the HSH, targets the hypnocytes that stay in the liver. And the way that we thought of to remember this was that since they go through reproduction, it takes energy to reproduce. So the first medications are ATP. For the blood stage schizonts, the VSS, that's when we move over to our blood stage. They get through the 5 different stages in the blood cells, and those target the schizonts before they replicate and enter your bloodstream as those merozoites that we learned about. And the way that we remember this is mosquitoes always carry disease around. Next slide. So the biggest thing we need to know from this is that it kind of just depends on where you're going and what medication you're taking as far as like when you do prophylactic treatment and what medications you're gonna be taking. Even if you do prophylaxis medication, you still need to be cautious about like wearing mosquito nets, wearing your uniform that has that permethrin in it. And then one other big takeaway is that you need to know that permethrin washes out in 50 washes, and you're not supposed to dry your uniforms either. Next slide.
Okay, so big thing with this, remember what we're talking about when we're saying prophylaxis, right? Before somebody gets somewhere. So a lot of our meds that we're gonna give, we're gonna make sure that they have those medications on board prior to them getting there. And then what she's also saying about our bed nets and all of those other things are like that extra layer of protection, so that you're not just relying on the medication, but you're also relying on like your uniform to help protect you, and then those bed nets depending on where you're going to help protect you as well.
And for this slide, you really need to know everything in the blue boxes. For mechanism of action, those are the two acronyms that we taught you guys for the medications. And then for the dosing, we did UDAP daily, so the DAP, don't know what DAP is, but UDAP daily. And then for weekly, you go to the TMC weekly for like medical issues. And then you'll have to remember that part on your own, just know the blue boxes.
So the big point with these, with when you start them, right? I could give you a patient and be like, hey, this patient is about to leave in a week. Or this patient is leaving in 4 days and they just now came up to you and they're telling you that they're leaving. So there's some medications now that are automatically gonna be off the table because they don't have enough time to get that medication built up in their system prophylactically before they get to wherever their destination is. So the idea is that I'm having that drug level where I need it to be prior to them getting to that site and getting bit by a mosquito, okay? So we're trying to have that drug already in the system, so if they do have that bug bite, we're not worried about it, because my medication is already working. And that's why you also see like post-travel, where we still have them taking it after. Don't worry about that, I'm more so worried about like when we take it. Both of them are very important, but you're gonna see this again when you do ID. And they'll probably make you remember when to start and stop. But what I want you to focus on is like, hey, when am I looking at making sure this person is started on that prophylaxis?
All right, and then lastly, kind of like I said before, your agent of choice is based off of mostly where you're going and then traveler specific factors. So military members traveling on orders, check your current policies and what the CDC is recommending for those potentially endemic areas. And then also some of these medications are like have contraindications, like if you're pregnant, you can't take some of them, or G6PD, you can't take some of them. It wasn't specified in this one, but just know that, and then I think that's it.
Yep. Y'all have been up these last 2 days. I love it. Yes.
Alright, can you hear me? Okay, so for quinolines, the one, can you hear me? Okay. For quinolines, the one thing that was on our little note thing is don't confuse these with fluoroquinolones. So like it was back in the chart, we were talking about BSS, HSS, and HSH. So your two BSSs are chloroquine and mefloquine, and then your HSS and HSH are primaquine, and we don't have the other one, so another group has that one.
You can still say it for us.
Tefenaquine?
Yeah.
Okay. Alright, so the spectrum, these are going to cover all the plasmodium for malaria. So we have plasmodium, falciparum, malaria, oval, and vivax, like we learned.
Now, I know that there is a difference between them, but I am going to just very generally say malaria. So if you're trying to remember, you don't need to remember the different stages, I'll just say malaria, blanket, and then you're gonna pick one of your meds, okay? So don't worry about your spectrum and all of the different, don't worry about it.
And everyone killed it in micro, so we know all those.
Yeah, so I can ask you this one.
No. That's not what I'm saying.
just kidding.
Someone take the mic from me.
That's not what I'm saying. Alright, so here are your agents that are gonna fall in this category. Some do have slides, so if they do have a slide, make sure you focus on those. But we're gonna go through the first three, and then we'll pass it on, and then we'll go through some of the other ones. So these do kill the plasmodium within the red blood cell, and that's how I was kind of talking about the BSS, HSS, and HSH like Casey was talking about. Okay. Alright, so for our first quinolone is chloroquine. Back on the chart, you can see that we're gonna take it 1 to 2 weeks prior to travel and 1 month after. And it's gonna treat malaria for uncomplicated. So the adverse reactions are gonna be pruritus, and then we're gonna get retinal damage, ototoxicity, myopathy, and peripheral neuropathy. So sounds pretty bad for adverse effects. But the contraindications is gonna focus more on your visual and retinal field changes.
So if somebody already has that underlying, because that is one of our adverse effects, we need to make sure that we're not predisposing them any more than we need to, okay?
Yeah, don't give it to them if they have that. Next slide, please. Okay. So for mefloquine, this one's gonna be a little different. It is 2 to 3 weeks prophylaxis. So we're gonna take it a little bit before. Like ma'am said, we need to, if they tell us like a week prior, we probably won't give this one. So this is gonna be for prophylaxis of falciparum and Vivax. And then we can have pharmacokinetics. Do we need to know that, ma'am?
So when you're looking at that, just understand it has a long half-life,
Super long half-life, 20 days.
long half-life.
Alright, and then for adverse reactions, we had for psychiatric disorders, vivid dreams, seizures, insomnia, some loss of balance and dizziness. So it's just gonna kind of get in your head and cause some. So if you have like PTSD, they probably won't give this. Is that correct?
So it depends, even like people who have seizure disorders, sometimes it will depend. It will depend, but for the most part, yeah, you can remember it that way, because some of those patients may be on like an antipsychotic medication, depending on how we're treating it. So we're very careful with it, but keep going,
Okay, so be careful.
be careful.
Alright, and then for drug interactions, the one thing that we highlighted was it causes QTC prolongation. So just, that's with your heart, so we don't wanna do that.
Okay, so mefloquine messes with your head, right? When we're looking at our adverse effects, and then that long half-life, right? QTC.
Alright, so for the black box warning, the one thing for mefloquine, it starts with M, so it's for moms. So we'll talk about that when we get to pregnancy. But for black box, like we kind of talked about, possible neurological side effects may persist and become permanent. So you are taking this for a pretty long time, so after you discontinue, it may become permanent. And then contraindications, kind of the same, what we talked about with epilepsy, seizure disorders, anxiety disorders, schizophrenia, and then psychosis and cardiac conduction defects. So if the patient has any of those, we probably won't give this one. And then for pregnancy, it's safe and good for mothers. So this is the one that we talked about. If they are a mom, we'll probably give this one if they're traveling into the areas that are gonna have malaria. This is the one. So M is for mom. And then exceptions, it's not established in patients below the age of 6 months. So the study showed if they're less than 6 months, you're not getting it.
So with this, make sure that you're just kind of trying to remember mefloquine, good for your pregnant patients, CNS effects, right? And then the heart, messes with your head, messes with your heart. So we had that QT prolongation, so if you remember your adverse effects, it will make sense for you to see your contraindications. You remember one, you can kind of be like, okay, I'm not gonna give this to a patient who has these, okay?
And that's all for us.
No. We have Primaquin, so this is HSS and HSH. So the big thing from this slide, it's indicated for treatment and radical cure, so it can prevent that relapse that we're worried about with Vivax and Ovali. And it's effective against pneumocystis jirovecii.
Hello. So for the Primaquin, the standard doses is gonna cause hemolysis, and I believe all of us know what that is, so I'm not gonna even explain it. For people that have G6PD deficiencies, it's gonna cause methemoglobinemia. And this one is particular target for people that have G6PD deficiencies because G6PD deficiency is unable to produce this enzyme that can reduce a hemoglobin into the methemoglobinemia. So in that case, the methemoglobinemia is unable to release the oxygen to the tissue. So it's critical for any patient to test for G6PD deficiency prior to prescribing them. And the adverse reactions is also the QT prolongation, the anemia, also the GI issue, and also watch out for any like skin reactions.
Okay. Okay, contraindications, if you have history of granulocytopenia, so basically low granulocytes, that's neutrophil, eosinophil, basophil. Methemoglobinemia, as mentioned already, or you're receiving bone marrow suppression drugs, you do not get this. Notable, avoid if you're trying to become pregnant, or if you are pregnant, this is for men and women. If your fetus is G6PD deficient, he may have hemolysis, he or she may have hemolysis. And in females, this will cause, so as I understand the slide, the female will have birth defects happen up to 1 month after finishing this med, and for males, the birth defects will last 3 months after finishing this dose. So you're deployed to Africa, don't fraternize with your privates while taking this.
So with this.
Preach.
I heard about some of that stuff. Tell me the truth. Whenever you're looking at this, right, with the avoiding if they are pregnant, right, I'm actively carrying or if I'm trying to get pregnant. This is one of those meds that's telling us like, hey, you have to have that washout period after that last dose. So if I'm a woman, I need to at least wait until I have one full menstrual cycle after I have been off of this medication. And for the males, they have to wait 3 months because that's when we're thinking that their sperm has like all of the sperm that should have had that medication in it will be gone. And so now they can try to start having a child if they would like to, okay? So that washout period is very important here, okay? Lots of blood stuff when we're talking about our Primaquin. Yes, what other drugs so far have we talked about in our other antibacteria lectures that we were worried about our QT? What's one class? Fluoroquinolones. There was another drug that has 2 components in it, SMX, TMP, Bactrim, yeah, and it had the sulfa in it. We talked about isoniazid, that was another one that had G6PD deficiency in it. So kind of like when you're looking at these and you see like those one-offs with stuff, put it in a column so that when you have a question, you can say, oh, that one of these drugs. I remember these drugs cause that. And then you go to that and you pick that in, okay? You know who to test when they come in. All right, sorry.
Okay, tafenoquine is another drug just like Primaquine. It has the same mechanism of action, HSS and HSS. It can be used primarily prophylaxis for malaria, and also one of the 2 agents that prevents the relapse. It is long-acting, fewer doses, lesser side effects. This is also used as a loading dose or daily for 3 days within 1 week of travel if you're about to deploy or go to endemic areas. Again, contraindications, G6PD deficient, and avoid if pregnant or trying to conceive. Just like how ma'am just said, 1 month and 3 months, so same thing.
Okay, so we're out of the lines now and looking at folate inhibitors. And specifically we have atropine and proguanil. And this is given as a combo pill.
What is going on?
Mic seems to be cutting out a bit, but this one is given as a combo pill. So I'll just talk loudly because it seems to keep cutting out. Given as a combo pill, and it is effective for both the blood and the hepatic stages here. It's normally given as prophylactic or uncomplicated malaria treatment. One big benefit to it is short duration for treatment, and short duration for prophylactic. So this one's only 1 to 2 days for the prophylactic treatment compared to some of the ones that are 2 to 3 weeks or longer. And then also decreased side effects and a little bit better tolerated than some of the other medications.
Did y'all hear that? Sorry. Yes, you're still there.
Malarone, adverse reaction included GI upset, mouth ulcers, insomnia, rash, headache, and can occur with higher dosages. Please avoid any renal impairment and pregnancy, breastfeeding considerations with infant
Y'all are gonna have to talk loud. Our mic is being real ratchet today.
Take with milk will increase the bioavailability by 5 times. So M&M, Malarone, milk, mouth ulcers.
So, big thing with this is make sure that you're understanding that if you have it with food, you're gonna see that increase. And both of these are, like when you see this flash, remember, both of these are components of the Malarone, of this medication. Both of these are in that one pill.
Before I start this, is that artemisinin?
Yes.
Okay, artemisinin. So we had artemisinin, our drug of choice for complicated malaria, which is a prodrug of dihydroartemisinin. Our biggest thing was, and we saw in our note, was it was very, very expensive, so they're generally kind of like only when you get that infection. The 2 different agents of artemisinins that we have are cotarin and artesunate. We were just kind of remembering these by everybody needs an ART when they're full of malaria. Because both the drug name or the brand name and the generic name both have ART in them. They co-ART, artesunate, artesunate, and artesunate methionate or methanor. So all the ART students have malaria. And then some other point, adverse reactions we have with ours, they're pretty well tolerated, but there is some nausea and vomiting, just like everybody else. Acute prolongation, just like every other drug, it seems like these days. And if artesunate is not available, there are some second line medications. I'm sorry, next slide. There are some second line medications that are available there that you can see. We have the Malarone, which is our second to go. Quinine sulfate or mefloquine. Obviously, our number one preferred because it's the most effective medication is going to be your artemisinin. However, you do have other options if you do not have the formulary or if they're too expensive. And finally, we have our prophylaxis, doxycycline, which works on the blood stage schizons. So what it does is it just prevents them from being able to get inside the red blood cells. You can take them as a chemoprophylaxis. They're especially good for falciform, that's right, in areas that have caloric resistance. So that's a really good, a lot of the places we go have the falciform. We never go anywhere nice, so there's some shitty. We use doxycycline. Other than that, we have beachhead learning, which is exciting.
Okay, so hold on. in New York or somewhere, they were on the East Coast. They were gonna fly them here for us to treat them here. So we had to contact the drug supplier to say, hey, can we get this medication? And what we were doing was, we were going to the P&T committee to say, do we wanna always have this? Or do we wanna just wait until someone comes and like try to keep them on the corridor until we can get the artesunate and put them on IV treatment? So probably not something that you will see stocked locally, this artesunate, but it is like one of the very good options that you have. Most places, we do have the corridor on stop, and if you wanna switch your patient, you could switch them to the artesunate, just know that it might be like a lag in between you actually getting it, depending on if your pharmacy that carries it or not. Here at BAMC, we do not carry it. Okay. Your check on learning,
Oh, you're reading.
you will get everybody to answer it.
For which of the following antibiotic agents has with the correct contraindication?
What we thinking? Bless you.
Left side,
Yes, it is.
A.
A, right? Okay. B, what was my age cut off for my doxy that we talked about? 8, right? And we saw this when we were looking at our antibacterial lectures. So same mechanism, not expecting for you to learn anything different there. Same rules kind of apply. This C is just not one of the two statements. And then looking at your Malaroon, was it hepatic or renal? Renal, okay? So seeing when you need to do those adjustments are kind of like some of the questions or the way that you could be asked some of the questions about these, okay? So that's why I told you. Mechanism of action, adverse effects, our contraindications, when can I use them, what blood stage am I targeting are your big thing. And if while we're doing this, you need to just go to the restroom, go ahead. Since we kind of started, relax.
No. Alright, so here's an image, we all know what this means. We all know what's going on here. So trichomoniasis is typically transmitted sexually. Don't let the name fool you, but it can get it too. Biggest thing here is our two treatments are metronidazole and tinidazole. It's a protein synthesis inhibitor. You're gonna see women be more symptomatic than men are. It appears that symptoms are very similar to other vaginal infections, but this is not bacterial vaginosis, so keep that on your differential. Any questions on this slide? Next slide. All right, raise your hand if you have cats. Raise your hand if you're a woman with a cat. All right.
Don't raise his hand.
All right, look out. So, so I have a cat, and I don't have a woman, but one lives with me. So, where'd she go? Stand up. Anyways, so for toxoplasmosis gondii, you want to be the change that you want to see in the world. So for this, you have cysts and oocytes. However, both of these will transform into tachyzoids, and tachyzoids can be dangerous to the fetus. So even though this seems relatively exotic, it is something that really may not be too far off from infecting some of the populations we'll see. So it's a combination of different drugs that you will use to treat this if it is something that comes across your desk. It can also be used prophylactically for people that may be immunocompromised.
So with this, you're worried about your pregnant women, right? So that's why you said cats and pregnant. So that's why we tell them not to change the litter box while they're pregnant, or like they're super masked up in gloves if they have no choice. So this is the combination that you'll see. They're gonna be on all 3 of So remember, a lot of our HIV, our AIDS patients, they have those, this was one of those opportunistic infections that we saw. So we are gonna prophylactically treat them, because if we think that they get sick with toxoplasmosis, this could be that one thing that takes them out, because they have the opportunity to do so. So we would prophylactically treat them and put them on that Bactrim. And that's where I was telling you, sometimes with our patients, that a lot of our HIV, our AIDS patients, we will see them on Bactrim, a lot of them. So Bactrim is the same thing, I'm sorry. Bactrim is the same thing as Cetra, which is the same thing that you will see annotated as your SMP, or SMX TMP. So I will add that to the slide for next go round. But this is like the same thing as Bactrim, sorry.
Amoebiasis. So just think of these as amoebas. That's what they are. Biggest thing here is you'll kind of have some general symptoms, some GI stuff. Kind of consider where you are, what kind of stuff you're consuming, where it's coming from. You can have these issues, and they can present with symptoms. They can also be asymptomatic. So sometimes it may be an incidental finding. Regardless, even if they are asymptomatic, if they're positive for it, it is something that we want to treat for. So so a couple different treatments here. You can either have your oral or your topicals. So paramomycin has a different mechanism of action than iodoquinol does. I don't know, the difference here would just be if you can see it or not, right? All right, yep. Yeah, no, so if you are symptomatic, you'll take metronidazole or tinidazole if they are symptomatic. So again, treat either way.
Okay, so the asymptomatic patients are getting treated just as well as our symptomatic patients. And when you're looking at your, if you had an asymptomatic patient, we are safe to use our paramomycin, so pregnancy with paramomycin versus with that adaquinol. The studies aren't fantastic, so that's why we don't typically use that for our pregnant women. Okay, so that's why you see the difference in those. And then you have your symptomatic, okay? And then you will follow on treatment with how you were essentially treating your asymptomatic patients, okay? Don't need you to know how long each phase of that is, just know that you're gonna treat them with that metronidazole or your tinidazole, and then you will follow on with what you treat your asymptomatic patients with.
Ma'am?
Yeah.
So on this one, so first just with metronidazole, and then after you're done with the dose of metronidazole, then with the pero, or together?
One after, yeah, so like you're gonna do this treatment first, and then you'll still kind of try to treat for a longer period of time with your asymptomatic drugs. Where's our group 6?
So for your giardiasis, basically, disease caused by commonly transmitted through water.
You're gonna have to talk loud.
Is it cut now?
Yep, there it goes.
Of my distance.
Okay.
Yes, commonly found in contaminated water. Just splashing around can cause transmission. I know my brother got this just from us splashing around in puddles. So the symptoms, the main one is malabsorption. So mostly from the nausea, vomiting, diarrhea, these line pretty much your entire intestines and bowels, so you can't absorb anything. And then for your treatment, the biggest thing is going to be the age for this. So if they're 4 weeks old to 3 years old, you'll give them the Metro. And if they're they're over 3 years old, it'll be the tinazole.
So, you are able to treat your patients. Where did we just see these two drugs? Right? Okay? So, lump these together. The thing to remember is the cutoff for my age. So, if you have somebody that's over 4 weeks old, cool, you can treat them with either of these meds. But if I told you that your patient was 2 years old, what option do you have? Metronidazole only, because I haven't reached the age of 3. If I told you that your patient was 5, I have either option, right? As long as they're over the age of 3, you can pick whichever drug you want. But you have to make sure that they're meeting that age cutoff for you to give them that medication. So if I was 2 weeks old, I'm not old enough to have my metronidazole, and then we're trying to be very creative, and ID would probably get involved to help you treat your patient, okay? So what I want you to remember is they need to be at least 28 days old for them to get their metronidazole, and then they need to be at least 3, it has T in tinidazole, right? They need to be at least 3 to get that tinidazole. Good.
Elements. Next slide. So you get the two groups, flatworms and roundworms. The biggest one we're going to focus on is the pinworm, Enterobius vermicularis. And then the primary thing to take away from this slide is that they hide in your intestines and come out and lay eggs at night, which causes scratching.
See this little baby up here? Daddy, my bum bum is itchy. They really, like when you lay down at night, they say like they feel itchy because the worm is kind of peeking out of the anus. So that's why they start to itch and they're moving, they're more active. And you're not moving, so now you can feel more movement. Okay, so it's nasty.
Yeah, so wash your hands. That's the biggest takeaway from that slide. That's important for you. Oh, also, on the last slide, it does say if one family member is infected, consider everyone infected. So just to clarify, would you treat all of them?
Yes.
Just give them the antiparasitic?
They come in and they wipe off the shelf because we are gonna have to treat everybody. It's uncomfortable for everybody because you don't know who's gonna get it, right? And until those worms start to grow, that's whenever they start to feel like the itchiness later. But if we can prevent it prophylactically, you're treating the entire family.
Next slide.
Okay, so big thing on this one, they're gonna have to do their laundry, okay? They can't use the same towel for that week, like they're gonna use the towel, they're gonna throw it in the laundry. Don't share towels, don't say like, oh, I'm getting my son out of the tub, and then I'm gonna get my daughter out of the tub, and I'm gonna use the same towel, no. Because, right, what if I have this pinworm that's in my towel? Same thing with their washcloths, if you're using washcloths, like make sure that you're changing all the linen, the bed linen, everything just needs to be cleaned, okay? Cut nails if they have long nails because if they're scratching, right? And now they have remnants in their fingernails, we wanna cut them. Good hand hygiene. Hygiene is a big part of this too.
So for your drug class for the pinworm, it's going to be your benzimidazole. And their mechanism of action is interfering with the elongation of the microtubules, which is what the pinworms are made up of. That's their cellular structure. So disrupting that will inhibit their growth and replication. And the two drugs we have for this class are albendazole and mebendazole, but it doesn't look like we could go into mebendazole.
They're very similar, I'll tell you.
So for our albendazole, some of the big takeaways are taking this with a high-fat meal, so you increase the absorption to the entire, if you have a systemic infection. And then your adverse reactions are liver, like increased liver enzymes, and so those should be monitored. And it is safe for pregnancy in the second and third trimester, but not the first.
Yes. So big thing with this that I also want you to look at is the age issue, again, right? So in how often you're typically having to do this. So a lot of the times we'll tell our patients to get 2 doses. If they're going on the outside and they're picking up these medications, most of the time, like Walgreens and CVS, we may not have a whole bunch of them on the shelf. And what you'll see is that we'll have an outbreak at school, essentially. So when you start to see one person come in, or if they come into the clinic, you see one person, you're usually gonna see a bunch of them come in because the kids are sharing restrooms, kids are being kids at school. So you'll see a lot of the families starting to come in and take everything off the shelf. So we'll just tell them like, hey, let's say your clinic is close to a certain Walgreens or CVS, say, hey, you might need to drive out a little bit further, especially if you've seen several patients who have been infected already, because they're gonna be running around town trying to find a net. So if they're over the age of 2, then you're giving them that 400, but if they're less than 2, then 200, right? So you can remember the age of 2 is again your cutoff. We keep looking at things, and a lot of these, our age is gonna be 2. But 400 if they're over 2, and if they're less than 2, then they have the 200. And then if you did write a prescription, remember that you need to give them a refill because most of the time this does not clear because of the hygiene portion of it. People continue to get reinfected, so they typically need another dose of the medication. Okay, so that's why you see sometimes we do 2 to 3 weeks. So 2 weeks, typically you'll see us doing that in our kids who are over 2, and then the 3 weeks is typically our repeat dose for our kids who are less than 2. Okay, we give them more time to kind of process that medication, and then they get another dose. So in practice, you should always just be giving them 2 doses. Is typically what we would do. Okay, so remember 2 doses. Your cutoff is the age of 2. 400 if they're over 2. If they're not over 2, then they're getting 200.
Alright, cool. Alright, so Dr. Jenny, I did what you told me to do. Did the tape, scotch tape on my kid. Yep, you got that one. Yeah, so,
Alright, so it looks like we have a 48, nope, just kidding, younger, 30 years old male come into my clinic with a child who have pinworms. So what are we gonna do? So we have this medication, it's called parental penoate. So what it does,
Not is hating on this whole performance.
Hello? Okay, so what it does is paralyze the parasite muscle. So if you see the name of the drug, it starts with P and P, and then you remember it's to paralyze the parasite. So that's easier to remember. And so what it indicates for is
No, you're good. You have your holder. It's working.
perfect. Alright, sorry. So what to use it for is for pinworm, roundworm, and hookworm. And you can get this medication over the counter. It's called Pinaway, very easy to remember, or Recess Pinworm Medicine. So it's just like candy, right? The adverse effect that you should worry for is just GI pain, so nausea, vomiting, diarrhea, abdominal pain, and you can increase your liver enzyme. You can also have dizzy, drowsiness, headache, insomnia, or rash. And so it sounds like your kid is over 3 years old, so you can safely give this medication. But under 2, there is no safety established to that. And do you have a wife, sir?
yeah, she's pregnant.
Okay, so this drug is actually perfect for your wife because it has minimal systemic absorption. So yeah, you can take it up.
Hey, that was good, y'all. So we see 2 again, right? So we see 2. And then when we're looking at this, sometimes it depends on when the parent found out. But if patients are saying that they get that insomnia or if they're very sensitive to meds, I'll tell them to just try to take it, depending on what it is. Sometimes I try to tell them to take it in the morning, but if they then experience that drowsiness, that's when you're like, oh great, now they're drowsy all day. So this is kind of a hit or miss where you just try it out with the patient and see where they're likely to want to do it. But I would not tell them to wait, right? Like I would not tell them to wait until the weekend and then figure out kind of what happens and then take the med. They need to take it right away. As soon as they know that they have pinworms, they need to start taking their medication because that worm will continue to grow and it's uncomfortable. Okay? Good job.
Cool. So now we're gonna roll into ectoparasites. So going back to micro, we'll talk about the lice. So we have the three kinds of lice. We have
Gotta have your holder back.
Is that working a little better?
Yeah.
Okay. We have three kinds of lice. We have the pediculosis corpus, because the core of our body, our core's in our body. The pubis is going to be the crabs, because they look like crabs. And the cactus is going to be the head, because you wear a cap on your head. Next slide. So to treat pediculosis, we use neurotoxins. We have permethrin and pyrethrins. The mechanism of action for these are they're going to work on the nerve cell membrane to disrupt the sodium channels, which we know is going to disrupt the polarization of the membrane. We'll go and talk about those two drugs on the next slide. For clinical use, these will be the first line agents against pediculosis, and they are not 100% ovicidal, which means they won't kill all the eggs. So you might have to reapply if necessary. An important part about these is you have to read the label, because some formulations are going to have benzoate or benzoic acid, which can be fatal to neonates. And then they might also have propylene glycol, which can cause issues in adults and children. So, next slide. So first we have the permethrin agents. You have nix and elamite. The way you remember nix is you're going to use nix to mix the lice in children that are over 2 months old. Then you have elamite, which is going to be used to treat Sarcoptes scabiei, which is caused by mites. So you're going to use elamite to eliminate mites. The next kind of neurotoxin is the pyrethrins with hyperonyl butoxide. And you're going to use these in kids that are over 2 years old. And the medication is RID. And the way you remember this is if you're older than 2, you'll take RID to rid your body of labs.
Bless you. Bless you. So with this, also what I want you to make sure you're understanding the difference in is that you have your over-the-counter and then you have your prescription. So the one that says RX, your elamite for your scabies, that one is prescription. Whereas you have your lice, you can get those over the counter. So think about it as like, hey, it's more common that somebody has lice, they can get these over the counter versus our scabies. So my friend is a pediatrician, and that's why I was like, trying to find. And so they had a patient, and they had to call Child Protective Services on the parent because they were trying to homeopathically treat the baby with lice. And the lice was in the baby's hair, in the diaper, like they could actively see lice, eyebrows, everywhere. And so they had to shave the baby completely. And so I was like, oh, so she took this picture, and I'll leave it up here so y'all can see. But like all of these little things that look like hair is just a bunch of lice, like on this baby's head. And I felt so bad for the baby. So then they had the grandmother also lived in the house with them too. And so the grandmother had lice, the parents had lice, the whole house had lice. So everybody had to shave everything. And I asked her about the kid. I was like, did they take the kid? And I don't remember if they took the kid or not from the parents. But sometimes homeopathic things, they may work, right? But we have medicine sometimes for certain things. So when you see situations, don't automatically assume that there was something wrong. And she advocated for the family because they were immigrants. And so they didn't understand and they didn't have insurance to bring the baby to the doctor. So that's why they also weren't coming to the doctor. And so they had to set them up with resources because sometimes people don't know what resources are available to them. Sometimes there's stigmas about going to the doctor. Sometimes I may say like, hey, somebody could show up to you and they're like in that condition to where it's that bad. So just be aware, like, oh goodness. She had her hair braided, she's like, I had to take out my hair and I just got it done. But everybody was just like trying to decontaminate themselves because they didn't know when they initially walked into the room and there was lice everywhere. Yes.
How do they like find the lice?
What do you mean?
Like, how they're like, I'm gonna treat you with lice, where do you go?
Where does who go? The patient? Are you talking?
Were they using lice for the treatment?
No, so the person had lice. They were using some kind of oils or something, like people will tell you to use different oils to get rid of the lice. Are you making a joke again? No, but sometimes I miss a joke. Why are y'all laughing? I'm trying to understand the question.
So like people use maggots, I don't know if people are using lice now.
People use maggots to do what?
Like to breed worms. You never thought,
I have never heard that. That's absolutely not. What? I have never heard that before, so that's new to me. To clean out wounds? Oh, so we don't just use leeches, we use maggots too. Oh, this is really fantastic.
I got a class on how to grow.
Go into my trash can. I just had to clean my trash can. There was so many maggots in there. I did not know that we use maggots.
We don't.
We said we don't use them, but people, okay. All right, come on, let's go next slide. Last little groupy group, and then I can kind of start going over some stuff with y'all real quick so that y'all can worry about eating. And then, all right, group A. Ooh.
Hello? Oh, wow, yeah, that works. Okay, so continuing on with the head lice, we have malathion next. It is going to have neurotoxic effects on the lice. And it's going to be your alternative to permethrin and the pyrethrin, Jesus. If there's resistance or if you treat it and then they fail, you're going to be using this. This has high ovicidal activity. So the brand name is Ovide, so I think Ovide is ovicidal, so just think it's going to kill your eggs. And for only those 2 and up, you're going to be using this.
So your big thing, and the way that I kind of try to remember this, exactly the brand name helps me remember like, okay, I'm getting the egg. Also, you see that this is a prescription, okay? So think about like resistance, right? I tried the over-the-counter stuff. I tried the more accessible, easier thing. Now I'm probably like panicking, right? I'm gonna go to the doctor because it's not working. What can I do to now help me get rid of the lice that I'm experiencing? So that's where you're seeing now. You have your prescription for your resistant forms of lice, okay? So now I need a doctor.
Okay, and so for precautions, these are going to be high alcohol containing, so alcohol is flammable. So no hair dryers, curling irons, and you're applying to dry hair. Next one, benzoyl alcohol lotion. Again, we have alcohol. This one's going to suffocate your lice, but not the nits. So the eggs and the nits are not going to be killed. So you're going to have to probably do multiple applications for this. Clinical use for this one is going to be your 6 months and older. What's that I have here? So avoid the use of pesticides and neurotoxins are the advantages of this, and they also lack resistance. This is a higher cost though compared to the other over-the-counter permethrin.
So when we think about these, right, anytime you think about prescriptions, especially if someone does not have insurance, then they're going to cost more. And then say if I don't have insurance, now I have to also pay for that doctor's visit to get the prescription for me to further treat my issue, okay? So thinking about all of the barriers is another big thing that you're looking at here. And then your age cutoff also, and your mechanism is different, okay? So watching out for your mechanism, watching out for your age is that we're looking for.
Okay, and our last one, ivermectin. This is a little different because it also comes PO and topical, also prescription only. This is a paralysis of the parasite. There's a couple different products. So there's a lotion
and that'll be for your 6 month and older than 6 months, so not 6 months. So the previous one is your 6 month and older, and then your ivermectin is older than 6 months.
I won't be that petty. I will be like, oh, they're 2 months, or I will be like, they're 10 months. I'm not gonna be like, they're 6 months or 10 months. I'm not gonna do that.
We also have a cream that also treats acne, and a PO version that's off-label for this. And adverse reactions, gonna be some eye stuff, so conjunctivitis, eye irritation, and then obviously these things are super irritating to your skin, so dandruff, dry skin, and burning sensation. And there's only gonna be one treatment for your lice, and then scabies is repeated doses.
So, these, when we're looking at this, just go through, I'm not worried about the spectrums of a lot of this stuff, know what you're treating, and then say, all right, here's the drug that I'm gonna use. What you see is that we have a lot of differences with our age cutoffs, and then our, where did this come, who gave us this? Who's red pen? Nobody's red pen? I'll leave red pen. Make sure that you're also looking at what will require you as a prescriber to prescribe, write a prescription for your patient versus not. And then those are the big things when we're looking at this lecture, okay? Do y'all wanna start trying to go through, like, just quick highlights of some of the stuff, that we'll talk about, and then whatever we don't finish, which is gonna be part of it, whatever we don't finish, then I can do on your lunchtime for Friday before I teach next door. Y'all wanna do that? Yes? If you don't want to, we're done with class, you can leave, also don't report, yes?
Just a question, so for this one and the previous drug, it's just greater than 6 months ago, right?
You can remember it that way, I'm not gonna be like, oh, 6 months, I won't ask you that way, but just remember it that way.